This talk is on medication-related osteonecrosis of the jaw. It's an important entity that I think is not well known, and it was formerly called bisphosphonate-related osteonecrosis. It's well known by clinicians, but I think not well known enough by radiologists. In this lecture, I'll start off by reviewing the normal radiographic appearance of the jaws, and then I'll go right into cases. I have 2 cases of medication-related osteonecrosis. I'll briefly discuss medication-related osteonecrosis and review its etiology and pathophysiology. I'll then show 2 unknown cases. These are cases that could be medication-related osteonecrosis, but don't quite meet the criteria or not enough clinical information was known to make the diagnosis. And this will lead into a discussion about the imaging differential diagnosis. And then finally, I will summarize the key points. There are 4 types of bone found within the maxillofacial skeleton, types 1 through 4. Type 1 is essentially cortical bone without any cancellous marrow. Type 2 is thick cortical bone but with a marrow cavity. Type 3 is thin cortical bone with dense trabecular bone of good strength. And then type 4 is very thin cortex with low density trabecular bone. So type 2 bone is most likely found in the mandible. The posterior maxilla is most likely to house type 4 bone. And this is actually the reason why implants in the posterior maxilla have a higher failure rate than elsewhere in the maxillofacial skeleton. And so just remember that types 2 through 4 may be normal in the jaws depending on situation, but type 1 bone is always abnormal. So there should be a marrow cavity pretty much everywhere. This is a panoramic radiograph demonstrating normal bone within the maxilla and mandible. You can see in the mandible there's a clear cortex and marrow cavity. And in the maxilla there is a very thin cortex. Most of it is the alveolar crest, but posterior to the teeth in the maxilla, this region here is called the tuberosity. And you really can't even see the cortex here, but it is there. But you can see how this is closer to that type 4 bone with a very thin cortex and thin trabeculation. So these 2 axial sections on CT bone windows are from 2 different patients. The one on the left is from a 16-year-old male, and the one on the right is from a middle-aged man. And I'm just trying to show the variability in what is considered normal. So on the left, you can see there's a nice smooth cortex with trabeculation. And on the right, you have cortex, you have cancellous bone. I would say the trabecula are a little bit more coarse and thickened in the older patient. And it could just be because these 2 patients are different, or the masticatory forces and the biomechanical stresses could be different, and that could be the cause of the thickened trabeculae. But either way, both of these are considered normal. This is an axial CT section through the mandible of a much older patient who is edentulous. And so you can see what happens to the jaw without teeth. The cortex becomes thinner, the trabeculae become thinner. And you could consider this normal aging. And it's also considered an atrophic mandible. That's the other term for this. So I've shown you the normal variation in the radiographic appearance of the jaws, but here are some definitely abnormal findings. Bone without soft tissue coverage, sequestra, essentially an island of bone floating in space, periosteal reaction, cortical expansion, cortical erosion, overlying soft tissue stranding, or a ground glass appearance. Here's our first case. This was a 68-year-old female with metastatic breast cancer taking IV bisphosphonates. And she presented, and you can see here in this intraoral photograph, there's necrotic and exposed bone in the maxilla, here and a little bit here. Here's her panoramic radiograph, and you can see there's multiple restored teeth and missing teeth, and there's clearly evidence of periodontal disease and some decayed root tips as well. But there's a lot of artifact over the central maxilla, and the exposed bone clinically is not appreciated on this radiographic exam. The CT, however, demonstrates definitely abnormal findings with cortical erosion, loss of the normal trabecular pattern, and there's clearly a mottled sclerotic appearance within the maxilla. This is the patient's bone scan, and you can see there's increased uptake in the maxilla. There's also a focus of increased uptake in the thoracic spine, and this corresponded to the patient's known vertebral body metastasis. The diagnosis in this case was medication-related osteonecrosis of the jaw, specifically from bisphosphonates. Here is case 2. Shown here is a panoramic radiograph, and unlike the last case I showed, I think you can clearly see that there's something wrong with this radiograph. Now, this patient presented with pain and exposed bone after a left posterior mandibular tooth extraction. And so there's sort of a generalized opacity of the mandible. You're not really seeing a clear cortex and medullary space. So kind of here, it's maybe a little too opaque, and here, this lucency here is actually just the superimposed airway over the mandible. And again, there is a cortex. You kind of lose it at the crest, but there's just an overall abnormal appearance, and you can see there's been an extraction in this area here. This bone right here looks a little abnormal, but difficult to say on panoramic radiograph. Here's the patient's maxillofacial CT scan, and I think now you can clearly see that this is abnormal. There is just general sclerosis, really bilateral, but greater on the left side posteriorly in the region of the extraction. There's a periosteal reaction, which remember was one of those definitely abnormal signs. And there's this bone right here, and it's as close as I think you're going to get radiographically to a sequestra. It's just a sclerotic piece of bone that's just kind of surrounded by what is called an involucrum. So the bone that surrounds the sequestra is called the involucrum. And this again is very abnormal. Here are additional CT sections, again demonstrating the sclerosis of the left posterior mandible as well as the sequestra of abnormal bone. And this case was also medication-related osteonecrosis of the jaw, also from bisphosphonates. The cause of medication-related osteonecrosis of the jaw is, of course, thought to be medication. Bisphosphonates, which are commonly used to treat metastatic disease to the bones or osteoporosis, those were the first medications that were implicated in this condition. But since then, other anti-resorptive agents such as RANKL inhibitors and anti-angiogenic medications have also been associated with this condition. And some of these medications are used to treat certain cancers like renal cell carcinoma. The pathophysiology is poorly understood. People think it may be from the anti-osteoclastic activity or the anti-angiogenic activity. Maybe an infection or inflammation sets it off. Some people think it's due to a fundamental problem in mucosal integrity, and immune dysfunction may play a role. The diagnosis of medication-related osteonecrosis is the following. The patient must have current or previous anti-resorptive or anti-angiogenic treatment. There must be exposed bone for greater than 8 weeks. There has to be no history of prior radiation and no known metastases to the jaws. This is very important. Here's the staging system for medication-related osteonecrosis, and the most important one I think is actually stage 0, which doesn't technically meet the diagnostic criteria. There's no exposed bone, but the patient has unexplained symptoms, and the patient may have radiographic changes such as sclerosis. So this is important because it's very subtle. And remember, sclerosis can be a little subjective, and one of the definitely abnormal findings may not be present, but this is the time where you may want to intervene. The patient may want to stop taking bisphosphonates or whatever the offending medication is. The next stage is stage 1, where you have exposed bone, but the patient may be asymptomatic and there's really no sign of active infection. And again, sometimes these can be treated with stoppage of the drug and antimicrobial rinses. Stage 2 is a little bit more severe. There's exposed necrotic bone. The patient is very symptomatic, and there's infection and erythema present clinically. As you move up in the staging, more surgical treatment is required. Stage 3 involves exposed bone, infection with purulence, and then often there's pathologic fracture or fistula formation. And sometimes these patients not only need debridement, but sometimes resection. So it's really important just to be aware of this stage 0, because the hope is that early diagnosis and treatment would prevent progression to stage 3. The risk factors for medication-related osteonecrosis are multiple, and of course medication use is a risk factor, and for the bisphosphonates, IV bisphosphonates carry a greater risk than oral. Duration of therapy is also important. Recent dental surgery and dental or periodontal disease have also been implicated as a risk factor for this condition, and I think this sometimes leads to the incorrect diagnosis. Remember, the appearance of this condition and osteomyelitis are very similar, and when a patient comes in with a history of dental or periodontal disease and maybe a recent extraction, and if you don't know that they're taking one of these medications, you're going to call it osteomyelitis. Comorbid conditions such as anemia and diabetes have also been associated with this condition, and then some genetic factors have also been associated with this. This slide reviews the imaging appearance of medication-related osteonecrosis. On plain films, it could be normal or appear normal because it's not detectable, especially in the case of the anterior maxilla, which is poorly imaged often on panoramic radiographs. The plain radiographs may show areas of opacity, lucency, or mixed areas, and it may show abnormal trabeculation or loss of cortex. CT scan may show sclerosis, or it may show one of those definitely abnormal findings such as erosion, periosteal reaction, sequestra, or surrounding soft tissue stranding. The MR appearance is somewhat variable. The sclerotic areas are decreased in intensity on T1, and the T2 is variable depending on how much edema is present. And the surrounding tissue may enhance with contrast, particularly in the setting of infection. The bone scan may be hot or cold. The necrotic bone itself is avascular and will be cold, but the surrounding inflammation and infection will be hot. Now I'd like to review some unknown cases. So what that means is the patient had a history of bisphosphonate use, but didn't quite meet the diagnostic criteria for bisphosphonate-related osteonecrosis or medication-related osteonecrosis. Now they may have, but we as the radiologists didn't have that information. Either we didn't know if there was exposed bone clinically or for how long, or whether or not they had a history of radiation therapy. So medication-related osteonecrosis was on the differential, but so were other conditions. This is unknown case 1. This was a 60-year-old man with a history of Langerhans cell histiocytosis and persistent jaw pain. He had received bisphosphonates in the past. And you can see that this mandible is grossly abnormal. It's kind of diffusely sclerotic. You can't really see the trabecular pattern. There are areas of cortical erosion bilaterally, and there is also a recent extraction site. Here are two coronal section CT in bone windows through the mandible, and you can again note the kind of diffuse sclerosis bilaterally. And on this coronal section here, you can see that there's some abnormal bone right here. This could be a sequestra. It's sometimes hard to know if it's a full island of bone or not, but that has a very abnormal appearance. It's surrounded by soft tissue, and so this finding is suspicious for a sequestra. For this case, we felt the differential diagnosis should include osteomyelitis and medication-related osteonecrosis. And the clinical history is going to be important because if this patient had exposed bone for greater than 8 weeks and had no history of radiation therapy or metastatic disease to the jaws and had taken bisphosphonates, which we know the patient did, then this by definition would be medication-related osteonecrosis. There could be infection, there could be osteomyelitis involved, but by definition it would be medication-related osteonecrosis. If it doesn't meet the criteria, then this case would probably represent osteomyelitis. Even if the patient did not meet criteria for medication-related osteonecrosis, I think this case would be osteomyelitis, but the fact that there's diffuse sclerosis of the mandible bilaterally, I don't think all of that can be explained by osteomyelitis. So I think the diffuse sclerosis is probably related to the bisphosphonate use. And so this patient could have osteomyelitis, but also have stage 0 medication-related osteonecrosis, which again, that stage 0 was sclerotic changes, symptoms, but no real exposed bone. Given the multifocality in this case, malignancy was felt to be less likely. Here's unknown case 2. This was a patient who had a history of breast cancer and had been taking bisphosphonates and presented with jaw pain. So this case I think is a little bit more subtle. There was just a little too much sclerosis in the marrow space. You can kind of see here and here. And a lot of it was centered around the root apices as well. And on the coronal section, again, I would point out this area and this area. So in this case, there were no definitely abnormal findings, so normal was on the differential. The other thing I would consider would be stage 0 medication-related osteonecrosis. If some of those sclerotic changes were related to the medication, then it could explain her symptoms, and this patient may not have exposed bone. I think it's important to mention the possibility of stage 0 medication-related osteonecrosis. They may not stop medication because of it, but maybe they'll refer to a dentist, make sure there's no infection that could trigger progression to stage 1 or 2, and maybe they would institute some oral rinses, or at the very least get closer follow-up. So I think if you see something that looks a little bit sclerotic and the patient's taking one of these medications, just mention it as a possibility. So as I mentioned, the imaging characteristics of medication-related osteonecrosis are nonspecific, and there is a differential diagnosis. Medication-related osteonecrosis, osteoradionecrosis, and osteomyelitis cannot be distinguished by imaging, and the history is what distinguishes those 3 entities. So if you ever mention one, at least consider the others and mention them if you can't exclude them by the history you have provided. Case A on the right is actually a case of osteoradionecrosis. Case B is a case of osteomyelitis. Case C is a case of what is called condensing osteitis. And this is when there is a sclerotic reaction to dental infection within the bone. It's not osteomyelitis. The infection is still localized to the tooth and the periapical tissues, but the surrounding bone becomes sclerotic. This would have a sclerotic appearance, but would not have one of those definitely abnormal findings. Tumor is really important and can definitely be put on the differential and should be put on the differential diagnosis for all of these conditions. And when I say tumor, I would include METs. Many METs are sclerotic. I would include osteosarcoma. And in fact, case D is actually a case of osteosarcoma of the jaw. Finally, there is an entity called cemento-osseous dysplasia, and it's a non-infectious sclerotic appearance of the jaws. It typically occurs in middle-aged African American women, but can occur in anybody. And unfortunately, I don't have an image example of that. I just want to go into a little more detail on condensing osteitis. This is the same case I just showed you on the previous slide, and the axial image on the left again just shows sclerosis. You can also see that there's maybe some widening of the periodontal ligament of some of the teeth, but on the coronal image you can certainly see that this left mandibular molar has a large amount of decay. There is a periapical radiolucency, and then you can clearly see the asymmetric sclerosis of the left mandible when compared to the right. So this is condensing osteitis. Again, there's no cortical erosion, none of those definitely abnormal findings. If you're wondering what that is, my guess is that is the inferior alveolar nerve canal, which you just can't see well on this side because there's no sclerotic bone around it. So here are the key points of this lecture. There's a variable appearance in medication-related osteonecrosis, and it can include sclerotic areas, lytic areas. I think sclerosis is probably the most consistent feature, but is also the most nonspecific. You really want to look for those definitely abnormal findings. And this is really important. You cannot distinguish osteomyelitis from medication-related osteonecrosis from osteoradionecrosis based on imaging, so you have to check the history. And remember, it's not just bisphosphonates anymore. The rank ligand inhibitors, the antibodies, as well as some of the anti-angiogenic medications given for cancer can also cause this condition. Bone scans are not helpful. It can be hot, it can be cold. Don't forget about stage 0 bisphosphonate-related osteonecrosis or medication-related osteonecrosis. This is subtle, it's hard to detect, but it provides an early opportunity to prevent progression. It is important to know condensing osteitis, and what's important to note about this, you don't want to call it osteomyelitis, but if you see it, just make sure they're not on one of those offending medications before you call it condensing osteitis. And remember that condensing osteitis will not have one of those definitely abnormal findings. And then finally, don't forget about cancer.